The lights are on, friends. The focus is on yourselves.
Oh, yeah, look. Yeah.
Today we are here for the
that's
session
fine.
on
That's fine.
Align for the Future with Myval Octapro transcatheter heart valve series, sponsored by Merrill Life Sciences. My name is Ashok Seth, and these are my potential conflicts of interest. We are here today to learn step by step the best practices of TAVI in valve-in-valve procedure. We also want to understand the design and implantation technique of a novel transcatheter heart valve, the Octapro. And we also want to update ourselves on the evidence base as well as the trials of the Myval transcatheter heart valve series, some of which are going to be presented during this meeting. This is the team you have for today. I will introduce myself. My colleague spokesperson is Felix, and we have procedural analyst with Luca here. Operators today are going to be Nicolas and Didier, who are at the clinic posture in Toulouse, with their cath lab medical coordinator, Bruno Farah, who you all know very well. We have some of the best in the world discussants sitting around the table here with Davide, Rand Karnowski, Martin, Sam, and Dirk. Our guest speakers for today are Rui, Patrick, Gilles Seco, and Christian, and we have an onstage medical coordinator in Omar with us. Do get onto your app, please. I know you've been using it for many other purposes, but this is the time to use your phones. Get onto the app, ask us questions, put your comments down. This is going to be a live case, and we'd love to interact with you. And we'd really make our effort and endeavor to answer the questions which come from the audience. There are microphones. You may get up and use them, but feel free. We want this to be interactive. We want this to be learning for all of us together. Felix, I think I'm going to ask you and my colleagues here to take up this session, and I think my first invite would be to Patrick, Professor Patrick Soros, to give us the Landmark randomized controlled trial subset analysis in small annulus. Over to you, Patrick.
So good afternoon. I will talk about the Landmark trial and give some data on small annulus analysis. This is my conflict of interest. And as you could see, it's well known that the Landmark trial is the first head-to-head RCT comparing the safety and effectiveness of Myval THV series with the contemporary THV series, the Sapien and Evolute. There is an embargo on one-year follow-up Landmark until tomorrow morning, so I have to talk about the 30 days and not the 1 year. I'm sorry for that, but I have to respect the rule. So you know about the Landmark. It's prospective, randomized, multi-center, open-label, non-inferiority. We were following the guideline of the SC and AAX. Here I'm presenting what has been published also in the Euro-intervention and not in the Lancet, the 2-1-1 randomization. And the primary composite endpoint is according to the per VARC3 at 30 days, non-inferiority of safety and effectiveness outcome. And you have here the two valves from the Myval series and the valve of the so-called contemporary series. Just this slide, which is some simple baseline characteristic. We are talking about 40 millimeters of mercury. We are talking about aortic valve area 0.7 centimeters square. Before the procedure, there was some degree of moderate severe regurgitation, but this is the important table for this afternoon. The aortic annulus area mean is 471, 469. 474. I mean, the aortic annulus perimeter is very similar, 78 millimeter. And here we have what we are going to discuss for 4 or 5 minutes, the aortic annulus area less than 430 millimeters square, 32.6% in the Myval, 33.3% in the Sapien, and 29.2% in the Evolute. Now, this is the pre-procedural aortic annulus area on the horizontal axis here versus the post-procedural AOA on the vertical axis. And you see here the Myval population. As you know, we had access to seven nominal size. This is a violation protocol with a 30.5. And what you see on this slide is the dot is proportional to the number of patients in each category. I have superimposed the nominal size here, going from 20, 20.5, 23, you know, every time a step of 1.5 millimeter. So that's for the Myval. Let's see what we found with the Sapien. The Sapien in red, you have again the nominal size of the Sapien, 20, 23, 26, and 29. You could see that this is standard deviation and mean. You could see that for the 20 millimeter Myval and Sapien, there is no difference in effective orifice area, but for the 23, the 26, and the 29, systematically the effective orifice area of the Myval is larger than the Sapien. Now, if we go to the Evolute, you see that the 26, there were no use of 23 in the trial, is as an effective orifice area larger and significantly larger than the Myval 23. Now let's do a smart analysis in the aortic analysis less than 430. This is the individual point. You could see the moderate and severe PVR in patients with a small annulus. In blue, the Evolute, there were 7 cases with moderate and severe PVR. Myval only 1, but you could see that in general, the effective orifice area of the Evolute was significantly larger than the Myval. And vice versa, the Myval was systematically at a systematically larger effective orifice area than the Sapien. There was 0 case of moderate and severe PVR in the Sapien. There are 1 case. These 1 case versus 7 case giving you a p-value of 0.007. So here you have the individual case of Evolute with the who has a moderate and severe PVR. What we have seen, and it's still in process, also in other trial, we have seen that, of course, when you put the 26 systematically in these small annulus, you got in supraannular vessel level, you get some eccentric elliptical appearance of the metal, and that makes suggest a pinwheeling effect. And indeed, 4 of these regurgitation is central, 3 is paravalvular. So my conclusion for tonight is, when compared to Myval nominal size 20, 21.5, 23, 20.5, there is apparently a disadvantage to oversize all the small annulus area below 430 millimeters square with a 26 and a 29 nominal size Evolute that generate at some point an elliptical orifice area, possibly a pinwheeling phenomenon, and a moderate aortic regurgitation. And I remind you that in the SMART trial, there was only 2.3% of 23 Evolute in the Landmark 0. Thank you very much.
Thank you very much, Patrick. Felix, do you have any comments to this very interesting analysis?
That's a very interesting one. Patrick, Can you remind us how many women as compared to men were included? And is
Sure.
there a difference between the two?
No,
analysis?
it's about 40-40, 50-50, 46 and 54 is the exact number. So this is a trial with almost half of the patient participant is female. And of course, these female fall in this small group. So it's quite interesting because we have something which is in hemodynamics very similar to the SMART study, but you have to wait for the clinical outcome. And if you look the literature yesterday, there was a letter in JCC intervention from Cologne. So you have Tanya Rudolph and Maury there saying, we don't see in our experience or registry in Cologne, we don't see this, we see this difference in hemodynamic, but we don't see any difference in clinical. So I think that the jury is still out and to see what is going to happen with time. We need time.
Patrick, that was interesting data. How about patient prosthesis mismatch? A lot has been made, of course, about the high rates of patient prosthesis mismatch in the SMART trial for SAPIEN. What was the rate of moderate severe patient prosthesis mismatch for the MyValve in this study?
Yeah, it's an interesting concept because, of course, you have the measured and you have the predicted, okay? Now, the measured, I think, as a matter of fact, if you have the effective orifice area and you have the multi-slice CT scan, in my mind, it's much more elegant to present what we call the fitting index, okay? And then clearly, with the multiple intermediate size, you can have a better fitting index than with the SAPIEN. I showed that, and of course, the Evolute. I showed that in London Valve last year, yeah.
Thank you. And I think we're going to move on in the interest of time. And we're here to understand a bit more about Myval Octapro, isn't it? And so I think I'm going to invite Rui to tell us more about the design and the science behind Myval Octapro. Rui, over to you.
So good afternoon, everybody. It's a great pleasure for me to be here. And it's always difficult to talk after Patrick. So it's very difficult, as you know. But anyway, so my task today is to talk about the science and design philosophy beyond Myval Octapro. And actually, philosophy is a theory or attitude that guides our behavior. And in 2020, we used the first MyValve in our center. And the question was, why do we need a new valve in our portfolio? Since I started TAVI in 2008, I still remember that before the first cases, I couldn't sleep because 10% of the patients died. And that was terrible. And I think only after several technical iterations and, of course, training, we achieved a standard where we don't think about it anymore. But this is still in my mind. That's why each time I have a possibility of innovation in my hands, I will always try to understand how useful that can be for our patients. And I think the question is, what are the main drivers of patients of device selection? Of course, it's different according to each one of us, but at the end of the day, it's always easy of use, individual training, and of course, evidence. Without evidence, we wouldn't be here. And I think that we know that in the last 10 years, there are only 7 trials that compare head-to-head different devices, and the last two are from the MyValve platforms. So I think that is important because since the beginning, that was one of the reasons that I saw that there was a commitment towards responsibility and research. So the basic feature of the MyValve platform is that since the number of TAVIs are growing everywhere and we need to have an expedited procedure, we need to have a simple platform, an accurate platform that has a short learning curve so that operators can start using right away. The current generation, the Octapro, has 2 rows of cells. The first one, the inflow, is octaedric and has a skirt, internal and external skirt, and avoids PVL. And the major feature that I found it nowadays is that There is no foreshortening at all. It's half foreshortening than the previous version. And that allows a very precise positioning along with the catheter that is provided with this valve. And the top cells are very wide and they allow good coronary access. Also, nonetheless, also very important, there is good possibility to have coronary access because there is a technique that was published that allows to orient the valve in a way that there are no struts in front at the left main or right coronary. So that is also important considering the long-term access to the coronaries. This was our first case with the current generation Octapro in February. And as you can see in this lady, it was a very stable deployment. Nothing special, but actually what is important is that it was really stable compared perhaps with other versions that we had in our hands. And coronary access was, of course, very easy, and you could even access the FFR at the LED that we had some doubts. Just to share the last case, a brief one, 78 years of age, a gentleman that had a type A aortic dissection in 2010 with a gel seal conduit in the ascending aorta and with a chronic dissection in the left and in the descending aorta. You can appreciate all the bending and dissection and how difficult it was to reach the ascending aorta. It was a case of pure AR, not as aortic stenosis, where, of course, as you can understand, it's very difficult to stabilize sometimes the valve. And here, what I can share is that in this case, we use the gel seal, a dry seal 26 to deploy the valve, and the valve was really stable despite being a pure AR case. And the result was extremely good, no pacing, so we were happy. And I think this platform can actually deliver, this is an off-label case, I should mention anyway, but it can have to actually deliver the valve in a very stable position. So having said that, the main goals of this philosophy is to have a device that allows a short procedure, that preserves coronaries, that reduces spacing, and that doesn't have pacing and PVL. Of course, the Myval Octapro is, as I mentioned, simple and very accurate, with almost no foreshortening. That is important. And the OctaAlign technique allows you to have a commissural alignment that, of course, facilitates lifetime management. Thanks a lot for your time.
Thank you very much, Rui. This is a novel balloon expandable valve. Thank you for demonstrating such lovely cases. Unique features. I mean, we saw minimal foreshortening, OctaAlign technique. What is that? There was an extra marker band that we saw on that valve. It seems to have 4 bands, which is very unusual.
Yeah, it's just a question of getting used to, but in the end, we have a marker that simplifies. Since in previous editions, of course, we had to have a parallax correction, and in this case, we don't have the same need. So I think it facilitates the deployment of the valve. But anyway, it's very precise. We can understand exactly where we should leave the valve, and in the end, what it's in my short practice, short experience, is that the valve does not move a lot. Or at all, I would say.
So you place it and you deploy it and it stays there, correct?
Yeah, that's what.
Well, I think we're going to watch this valve in action in the case. And I'm therefore going to ask Felix to present the case so that we know more about this valve.
Thank you very much indeed. I'm going to briefly present the patient history and the patient that we're going to see in a second in the live case. So we will see a valve-in-valve procedure in an 82-year-old male that has been admitted to the hospital with acute heart failure, symptoms of acute heart failure due to failing bioprosthesis valve. The patient suffers from permanent atrial fibrillation. He has undergone surgical aortic valve replacement and ascending aorta replacement back in 2013. There's a pacemaker implanted due to an AV block 3 back in 2018. There is an aortic valve degeneration with severe regurg and preserved ejection fraction, and a coronary angiography performed at another center revealed no significant coronary artery disease in the patient. So the patient details, to summarize, we'll see the cardiovascular risk factors as hypertension and past smoker. The clinical presentation here is acute decompensated heart failure with New York Functional Class 3. Body mass index is 25 kilograms per square meter. Sedentary lifestyle, and the patient is independent at home. Medical therapy consists of the major pillars for treatment of acute heart failure, as I guess listed here: beta blocker, a statin, a apixaban for the atrial fibrillation, an ACE inhibitor, SGLT2 inhibitor, and a mineralocorticoid receptor antagonist, and a loop diuretic. Most importantly, the laboratory investigations are shown here. Hemoglobin is 13, almost 14 milligrams per deciliter. NT-proBNP was elevated because of the decompensated heart failure, 4,400, and eGFR was mildly reduced with 46 mLs per minute. You'll see more about this in a second, but if you want to summarize the echo findings, you will see a dilated left ventricular and diastolic diameter 64, the ejection fraction of 65%, a severe intraprostatic aortic regurg, a mean aortic gradient of 27 millimeters of mercury with a max velocity of almost 4 meters per second, a moderate secondary MR, and an elevated systolic pulmonary arterial pressure of 71 millimeters of mercury. So this 82-year-old patient with prohibitive surgical risk due to the failing aortic valve and the ascending aortic aneurysm was then discussed in the heart team at Clinique Pasteur. A surgical reintervention was denied and excluded, and what we will see today is a transfemoral valve-in-valve TAVI first, and then a percutaneous exclusion of the false aneurysm in a staged procedure. This is a summary of my case presentation here. Again, an 82-year-old patient with prohibitive surgical risk who has undergone aortic valve replacement with a Mosaic 27 millimeter valve. And now we're seeing a mixed degeneration, the leading regurg, but also a stenotic component, a stable ascending aortic false aneurysm that will be repaired in a staged procedure. And we're going to see in a second now a valve-in-valve transfemoral TAVI. With that, I'd like to hand over to Luca, and he'll guide you through the CT analysis.
Yes, thank you very much. Am I on? Okay, okay. So now, I will start from actually, is that, please can you connect on the table, on the big screen? It's not visible there. Just give a second, Okay, so these are my disclosures. Okay, let me start from what is still the most important thing nowadays in 2025, so it's the femoral axis. As you can see here, there is a little of concern if you've gone on the left side, because we got a 5.4 millimeters with some calcification, almost a ring. But if you look at the right side, you got some bends, but it's definitely accessible. So I would say that probably the operators will go through the right side, and which is honestly a right choice. And then we need to see what is the path. So we know that there is this aneurysm as a consequence of the surgery 12 years before maybe. And then, as a matter of fact, we also need to evaluate the aorta. As you can see here, there's not a specific bend, so I would say that this is not a problem at all. So it's going to be a normal pathway, normal course for the prosthesis. And then we go to there. So one of the main concerns when we are doing valve-in-valve procedures, either with a transcatheter aortic valve or a surgical valve, is the VTC. So the valve to coronary distance. As you can see on the left side, we got a lot of space because it's in the range of 7, so it's way higher than the, let's say, threshold of 4. When if you look at the right side, it's questionable. We see what the operators think to do, but it's in the range of 3.6, so slightly shorter than the 4 millimeters threshold that you think is the gold number. So this is just to show you what we are talking about in terms of pseudon aneurysms. So it's located just above the SDJ junction. So in other words, it's not really interacting with the bioprosthesis. So I have to say, I totally agree with the idea of fixing a valve first and then to think about what to do next with this. Honestly, we don't really know the timing of this aneurysm. Nevertheless, it's also conceivable that it's there since a long time. Nevertheless, this is not the focus for today. We can think about that next time. So, another consideration here, because of course I simulated the interaction of a new valve inside the first one with this pseudoaneurysm, and you see there's no interaction at all. So again, it's just to confirm this is not a matter of concern for us. But definitely we need to discuss some other points here, because the STJ, as I told you before, is not really giving us any headache. The anatomy of this specific patient gets much bigger in the ascending aorta. But as we said before, this is probably a consequence of the surgical treatment. And again, this is the through STJ junction, and you can see the aneurysm on the left side is not really interacting at the level of the valve. So, we are close to the end, but I want to show you something that is interesting, because as Felix pointed out before, this is a mosaic 27. So from the manufacturer information, we know that the true ED is 22. So that's the number we need to look at every time we are doing valve-in-valve, because it tells us what is the specific size of the bioprosthesis we are going to implant. And as you can see here, I use the app that we are using every day, and it tells us something like 23 or 24.5. And of course, we discussed a lot about this point. We also need to see that according to the app that we are using today, this mosaic 27 appears to be, what we can discuss again, that is fracturable if we use a true balloon, non-compliant balloon, with 26 millimeters. This is questionable in my mind, but I don't want to anticipate other focus for the discussion. Last slide I want to show you is the simulation. So I simulated 21.5 and a 23 on the right side, just to give you, the background of what we are going to discuss. Obviously, we are not going to take off the leaflets, so the leaflets will be there forever. So we need to consider there will be some space occupied by the surgical bioprosthesis. So in other words, we can either think about 25.5, just to minimize the risk of PPM, or we can think about the 23, knowing that might be some pinwheeling, that might be some gradient at the end. Okay? So I stop here and give the word to the heart team and the operators and enjoy the live case.
Thank you. Thank you very much, Luca. That was great analysis. We've all now known about the case, the patient, the details. I'd like to remind you, please put your comments into the app. Felix is looking at your questions, your comments as we discuss it amongst the panel here, the heart team. Martin, this is to you. We've got a situation out here where we firstly got to discuss what valve to use. We may be in an OctaPro session, but we all have our own experiences around what we want to use. We have the supraannular self-expandable, we've got the intraannular self-expandable, we've got the balloon expandable valve. So what in your assessment would be your choice in this case?
Thanks, Ashok. There are multiple considerations here. And one of the unique aspects of this patient is that aortic pseudoaneurysm, the ascending aortic pseudoaneurysm, just above the sinotubular junction. Look, there's an indication here to actually, the current thinking is that you should repair it. The patient's not for surgery. There's an intent to fix this percutaneously. Now, and this aneurysm is just above the sinotubular junction. Now, if you put a supraannular device there, I think the problem here is that access then to the pseudoaneurysm repair would be technically challenging. Obviously, with valve-in-valve, hemodynamics are key. This is a 27 millimeter mosaic, so it's not a small bioprosthesis per se. And so I think, actually, if you think about this, a short valve, in other words, a balloon expandable valve, has an advantage here because it won't compromise access to the second intervention, in other words, the closure of the pseudoaneurysm. And secondly, I think that the hemodynamics that you're going to be able to achieve in a 27 millimeter mosaic with a balloon expandable valve would be good. Of course, there's always an option to fracture as well.
Right, so all good points. And even the ability to flex the valve,
yes.
The interaction between that aortic graft versus a short frame valve is going to be lesser.
Yes, of course. I think the balloon expandable systems, being able to have that flexible catheter, to avoid against interaction with the pseudoaneurysm is another plus.
Yeah. Sam, do you really think that balloon expandable valve would be your choice as well? And if it was, is it going to be a choice?
Yeah,
I don't want to assume it.
Well, Ashok, we in our center, most of our TAV and SAV on relatively small surgical annulus would be a self-expanding supraannular. But I think there are very cogent regions for what Martin has highlighted, and also just delivery of the self-expanding into the small annulus. You really want to avoid any further trauma on that ascending aorta, right?
Right. So my next question to you would be sizing. I mean, that's always a challenge in a valve-in-valve situation.
So I think the CT dimensions, so if we start back and look at the patient, he's 82. His first valve, surgical valve, lasted 12 years. He's relatively small, BMI was 25. Even not knowing the post-surgical gradients, I think we can assume that there was no PPM concerns here, right? So this valve has failed after 12 years, largely with pure AI. So what that means for us is that we just have to replicate the effective orifice area of the original surgical valve. And I think when you did your measurements, Luca, you got around 21.5, taking into account the pannus, these sort of things. Yeah. So I think it does bring up the option of using that 21.5, that intermediate valve versus a 23, and then a Myval because of the ability for foreshortening being minimized and commissural alignment. I think that's important. This man has no coring disease, but that may also be important commissurally aligning for allowing the valve to work as long as possible. So in this man, I would favor the 21.5, maybe add it a CC, you deploy it at nominal plus. The challenge with the 23, whether it's a Myval or Sapien, is you will dog bone a little bit, and you may actually get some pinwheeling. So I think really we need one valve for the future of this man, well deployed. Yeah.
Okay. There's a question from a colleague in the audience pointing to what you were saying. Would your choice being different whether you use a Myval or a Sapien valve in that case?
Well, so I wouldn't use a 20 Sapien here. I think I would use a 23 Sapien, but it will dog bone. So we're not trying to fracture this valve, right? Because we go back and say PPM wasn't an issue here, right? We just need to replicate the effective orifice area of the original surgical valve to give it durability.
So that was a great question around intermediate sizing, which brings me to Davide. So we saw the landmark data, and we saw the large effective orifice areas from the Myval compared to the Sapien. Does that data, now that we're talking about valve-in-valve, we're talking about, does the landmark data extrapolate into a valve-in-valve? What are your feelings around this part of that issue where the justification just came in for a large effect orifice areas?
Data to this case, because of course we need to be aware that in the Landmark trial at 0% of valve-in-valve, and in the COMPARE TAVI 1 there was 4%. So both studies are not really relevant to a case like that, although in COMPARE TAVI 1 at least we have some data to generate subgroups and meaningful subgroups. However, there are some characteristics of this valve that we have seen in the presentation of Professor Serois that are relevant to this case, particularly the AOA, because we cannot use a tall frame valve, so we have to use a short frame valve. So I think it's important to use the one with the best EOA to avoid, of course, the degeneration and gradient mismatch.
So I think that's at least puts us in a position to start understanding that it's going to be a balloon expandable valve. We all more or less agree to that, and we're going to be seeing OctaAlign in use. So Ryan, let's get to the technique of it now. Do you want to pre-dilate this valve? Do you want just a direct implantation? What's your technique of a valve-in-valve?
So I would like to touch base on several aspects, procedural aspects. One, it seems that the coronary is not a main issue here, so there is no need for leaflet modification. Since this is a mainly aortic regurgitation case as the mode of bioprosthetic failure, I don't think there is any need for pre-dilatation. One may raise the issue of cerebral embolic protection. I don't think there is a strong indication to use it in this case, but again, this is an operator discretion. I would avoid fracturing because I don't think PPM would be an issue with the 27 millimeter mosaic, and I would be very cautious with this fragile aorta, which is already aneurysmatic, so who knows what's going to happen if we fracture it, and I don't think it's necessary. And post-dilatation might be needed depending on residual gradients, especially if we are using 21.5. I'm not sure it would be necessary with 23 millimeter. So this is pretty much going to be my proposed strategy.
Thank you. And then I thought you raised a great point around cerebral protection, and I would like to go around the table. These are fragile thrombosed, degenerated leaflets. I mean, they would, to me, represent the highest chances, even though you may say the BHF data just didn't support it enough, but that's not the point. So David, let's start from you. Cerebral protection, yes or no?
No, 2 trials are negative, and tomorrow we will see the meta-analysis, maybe.
Ran's already said that. Okay, Dirk, yourself, cerebral protection, yes, no?
Clear no, unless it's included in the study.
No for me as well.
So Felix,
No.
And we tend to use for valve and valves.
No.
Luca,
No.
yes. I'm not supposed to say that, am I? Okay, let's move on to the final. And Dirk.
Can I raise one more point?
Yes, you do raise another point, and I'm going to ask you something else.
Sure. I'm really interested whether or which wire actually the investigators are going to use, because with the balloon expandable valves with that relatively larger order, I think we need a little bit more stiffer wire to really pass into the valve and valve, which is a little bit smaller. I haven't seen, Luca, the angle of the aortic valve, so it might be a little bit difficult if you take a too soft wire to enter the valve into the...
Well, it's, from the analysis of the CT scan, one thing was evident. I mean, the thoracic aorta was really large with a really steep angle. Nevertheless, the ascending aorta was relatively fine. It was not,
Okay.
the angle was favorable, I would say. Nevertheless, it's a good point. Because once you cross into the aortic arch, doing the, let's say, the curve or the ascending aorta might be a problem. Let's see what the operators do, but definitely in this case, I would evaluate and consider something stiffer.
Yeah.
So
than the workhorse.
let's now move to Nicolas and Didier. They're up on the screen, and we're looking forward to your case. Didier, Nicolas, we see you. Can you see us and hear us?
Yes, Ashok, perfectly. We hear you loud and clear. And you, can you hear us?
Absolutely. You look great.
Great, great. So, welcome to Clinique Pasteur for this last live case of the day. We heard your discussion, and I must say, Didier, we are perfectly aligned of
Can you
with
just
all what you said.
can you just excuse me for a moment that I give your objectives as well as your plan strategy to everyone? So you know we have the operators, Didier and Nicolas, and these are the conflicts. They are going to review and take us to the key steps of Myval Octapro implantation in this degenerated surgical bioprosthesis. And we're also going to discuss and hear from them the optimization of hemodynamics during this aortic valve-in-valve implantation. They're going to plan this under conscious sedation, echo-guided puncture of the common right femoral artery, a single ProGlide pre-closure technique, and they've selected an Octapro 21.5 millimeter valve for this implantation. They're going to measure the invasive gradients at the end of the procedure, and if needed, they're going to modify this valve, the mosaic valve, with an Atlas 22 millimeter post-dilatation. Both Nicolas and Didier are going to be assisted by Nurse Claire and Melody. The anesthesiologist with them is Laurent, and the radiographer is Elodie, and the medical coordinator is Bruno Farah today with them. With that, we're over to you, Nicolas and Didier.
Thank you, Ashok. So I think you summarized perfectly the main lines of our strategy. So Didier, without further waiting, I think you can tell to our colleagues where we are.
Yeah, sure. The setup of the patient, briefly to describe it. We have a right radial access for the cerebral protection device that you can see. If vous pouvez montrer là, ici. Okay, the cerebral protection device. I did the echo-guided puncture of the right common femoral artery, and I used the left common femoral artery for the pigtail. I didn't use the left radial, but this could have been an option as well. If you now focus on the angio, it's of interest for two reasons, Nico. The first one is that we can see that there is a massive regurgitation, but we know that based on the history of the patient. And at the same time, we have a nice view that aligns the commissures of the posts of the mosaic. And another important information is that we don't really see the origin of the aneurysm, but based on the CT, we know that roughly it's going to be on the more on the right part of the screen if we have to make it clearer for the audience. If you have a look at the hemodynamics, it's quite interesting to see how low is the diastolic aortic pressure. 130 over 40. So here we are about to cross. And we will try to cross with a pigtail, Nick. Yeah. And see if we can get to that. Because it's a regurgitation, so normally it shouldn't be too difficult to cross. There's no major issues regarding a potential paravalvular regurgitation, but sometimes that's something that we discover during the case. So we will see how it goes with once the valve has been implanted.
So yeah, Didier, and I think another very important information you all have under your eyes here is the visual signature of a mosaic valve. Once you know it, it's okay, but when it's the first time you treat a patient with valve, it can be something that is a little bit unusual. So the only radiopaque markers, the three islets that you see, are at the top of the posts. Yeah. And not at the base of a swing ring of a bioprosthesis. So it will have a consequence on our positioning.
A very important.
Yeah. So Didier, let's have a look at the hemodynamics.
Yeah, please.
So as you mentioned, we have I would say the typical hemodynamic pattern of severe aortic regurgitation with a very small difference between the aortic diastolic and the LV and diastolic pressure, which is not too high. It's quite elevated. It's not normal, but it's not too high. So you saw the patient had a high dose of diuretics. He was pre-treated before the intervention, and also as a consequence of this increased flow that we have related to VAR, we have also a small integrate gradient, which is not very, very important. So we have those measurements in mind, Didier. Yeah, Ashok.
So we're going to ask you. Just describe this overlap view that you really want to see. Is it a 2-1? Have you overlapped the post? Is that what you're doing in trying to, say, get perpendicular or remove the parallax from the valve?
Yeah.
Yeah, exactly.
Yeah, it's exactly that. And as Nico has mentioned, the islets are located on top of the post, at the upper portion of the post. So it's a very visual landmark that we're going to use, and it's going to serve as a reference to position the valve as well. We heard the discussion that you had concerning the complexity of the aorta from both Ran and Luca. So what we're going to do is to use a stiffer wire as compared to what we use regularly. For a typical Octapro case, it would have been a Safari S. Yeah. But here, what we're going to use together is a Lunderquist double curve. So more supportive wire, but still kind of gentle in terms of keeping the integrity of the left ventricle. So it's a Lunderquist double curve, and we're going to expand it through the pigtail. So to achieve that, what we're going to do is to move to that LAO projection, RAO projection, because it's a highly supportive wire, and what you want is to make sure that you're going to expand the radiopaque portion without too much interaction with the left ventricle.
Is it okay for you like that?
Yeah. So would you use something different, Ashok?
I'm going to ask around the table. Anybody use a different wire? I mean, we discussed it here, and Lunderquist was one of the wires which we said that we would, most of us would use it.
Didier and Nicola, there are a couple of questions in the chat asking why you have picked the 21.5 millimeter valve, because the app nicely showed that you may consider 23 or 24.5. What made you finally drive the decision of using the 21.5? Can you summarize that?
Let's summarize that. First, I think the first reason is that as it happens almost always or very often, at least for us in our center, but I don't know if we share this experience with everybody, there is a huge discrepancy, or a significant discrepancy between what it's supposed to be, meaning what is written in the surgical report, here Mosaic 27, and what we actually measure. And what we measured actually was more in line with a smaller mosaic. And it's something what we almost always see here. So as a consequence, we mostly rely on the actual measurement done by a CT scan of a true ID. But here was smaller than the one supposed to be in a Mosaic 27. And based on this measurement, we thought that the 21.5 would offer the best option in order to have a proper sealing, a good hemodynamic function, while avoiding the risk of pinwheeling effect with a bigger valve that would maybe alter the hemodynamic function.
Yeah, exactly. So 21.5 OctaPro.
And have you done the OctaAlign? Are you going with an OctaAlign technique, Didier?
Yeah. That's what we aimed at. So the valve has been crimped in a way to optimize the commissural alignment, but we will have to adapt because once again this is a more challenging anatomy than what we see usually. Okay.
You're going to use the flexibility of a catheter across the arch.
Yeah.
For the reasons we've mentioned, related to the particular features of this patient, especially regarding the ascending aorta.
Exactly. So let's here I guess we can slightly pull on the wire, and you see how easy it is. And let me maybe stop here. We're going to go back to the cusp of a lab projection. That was a LAO4 caudal 15, I guess. Yeah, this was the projection, a bit more of caudal.
Yeah, like that.
And LAO. Okay, here we are. So here it's really nice to see that we are kind of central for the audience based on the the flex system of the delivery system. So it's really important because we got rid of any major friction with the ascending aorta. So now we're gonna cross, and it's gonna be another important point of discussion about the how we are going to position the device.
Exactly.
Just to try to get a good alignment with the highlights. As one could expect, we have a quite important yo-yo effect, back and forth movement. So Melody, what you can do is to pace at 120, 120. We're just going to fast pace. It's pacing over the wire. It might be slightly more difficult with the Landoquist. Tu peux pacer en permanence.
So how are you going to align
just to stabilize
this valve?
things. Yeah.
Could you just expand on that? Obviously, all you see is the post, the upper end of the post. So how are you going to align this valve? The depth?
Yeah, what we see are the posts. So what we're going to do is to be slightly below the post, and we're going to do a root shot like that. This. Yeah. Perfect. So Claire, you can inject. Okay. Yeah. So as compared to what we do regularly, usually what we do is to put Nico the marker just slightly at the annulus or slightly above.
Yeah.
But here with the main landmark are the post, so we can be slightly higher.
I think so. Yeah. I would go maybe 1 or 2 millimeter higher. And
So I will let you just slightly push on the wire just to keep the perpendicularity. And I will go back, Like that, it's better.
I think like that is better,
Okay, excellent. So what do you think about the position here in Paris?
Good. Looks good, yeah.
Okay.
And
so we're going to pace at 180 now.
And it's going to stay in that position. And that's what you want to see?
We're gonna check that before.
Yep.
Or maybe
190, 200. Let's have a look at the hemodynamics. And now it's beta. Okay. So let's inject, Claire. Okay, and you can go, Nico. Okay, perfect. You can go fully Yeah, you see the resistance that you have.
Yeah.
Okay, deflation. Okay. And pacing off. Definitely we will have to post-dilate that, I guess.
And maybe the sound I made while inflating the valve revealed that, but I must say that I had a difficult effort to make to inflate and to fill in the balloon.
So another option is to let's use to once again do a post-deal directly with the balloon, and then we'll use a bigger one.
Yeah.
Because it was a 21.5 plus 2 cc.
Yeah.
So 200 once again, Melody. Thank you. And we can see how accurate it is to do the fast pacing with even with a Lunderquist. Okay, perfect. Yeah. I'm going to go slightly higher. And all your muscles. Yeah. Okay, deflation and pacing off. Perfect. So let's see if the patient is still in sinus rhythm.
Yeah, he's having the pacemaker with.
Yeah. Okay. He is.
Yeah.
So can you play the first the implantation run? Just to emphasize how it stays into position.
Definitely, Ashok. So we will bring the pigtail back, and meanwhile, I'm just going to rewind the first expansion. Tu peux appuyer sur séquence, rappeler séquence et celle d'avant, s'il te plaît, Claire. Celle d'avant.
We just wanted to see the precise expansion and minimal foreshortening of this valve.
Tu peux nous montrer la séquence d'avant, Melo, va de l'autre côté. Yeah, we're going to fix that technical bug that we have with the cine, but we're going to show it to you. Vas-y, montre-nous la séquence d'avant. Celle-là, elle est bien. So, this was the deployment. We can see how stable is that device. You can really target either the inflow or even either the outflow or even the inflow, because it remains quite stable with a minimal foreshortening. And here, the choice of a 21.5 makes sense, because we can clearly see that the ability to expand is really minimal here. If it was a 23, the pinwheeling effect would have been even more important.
I can just emphasize that, in other words, on the safe side, and we underline the frailty of the aorta of this guy. So I would go maybe for a pulse dilatation with a 22 millimeter balloon, for example.
Yeah. Would you use a non-compliant balloon like an Atlas? Or
no, I would say
just to stretch.
Yeah, a standard balloon just to improve the expansion, but for sure not in first intention for a BVF with a more aggressive non-compliant balloon. I don't know what you think, looking at the gradients and you have under the highs.
So Nick and DJ at Sam, other question. Yeah, it looks really good. And your hemodynamics are excellent. We haven't seen an aortic root shot, but your separation diastole is huge. I would tend to accept this. I don't know. You've already put in 2 cc's, right? Additional cc's into the original expansion with the 21.5, correct?
Yeah.
Yeah.
Yeah, I mean, I think it looks good. I would be tempted to leave this.
The only point to maybe entering in the discussion is that if you look at carefully at the frame, we see a kind of waste.
Yeah, there is still a waste
at the middle of the stand. I'm not sure we will be able to solve that. Honestly, but that's what is making me think that we could try at least to improve that mechanical expansion.
The only way would be to go for a kind of fracture-like procedure.
Yeah.
And given the risks that have been described, maybe it's not the wisest solution.
No, I don't think so.
So we'll go for a stretching with a 22 millimeter balloon only, just to make sure that we have anything that is...
Which is at least, I think, Didier, something more we can do that maybe help or maybe not, we'll see, but that should be safe.
Yeah.
So while you're doing that, Didier, is it, not just in this case, is it your normal practice for a balloon expandable valve, at least in valve or heavily calcified, to really hit it twice or post-dilate it twice?
Exactly. Yeah, that's a very important comment, Ashok. And I think in contemporary practice, one cannot only accept to deploy the valve and be happy. We have to work on the hemodynamics because we have these new generation platforms that can achieve superb hemodynamics. Yep. Whether we use a balloon expandable platform or another one, we would go for a more aggressive treatment per procedure to make sure that we get zero gradient and we get a valve that is as expanded as it is meant to be.
Yeah, so I'm okay for you to go in with this at least, and let me poll around the table because I'm okay with what you're doing, and I think getting the maximum gain. There's pannus there, there's tissue there. You need to push that as far as possible. So just to accept, does hemodynamics is no more. You go ahead. We won't interrupt.
Same here. Okay, deflation. And
not much change.
Yeah, no.
So my comment was that I'm great with what you're doing. Just the endpoint of hemodynamics and no gradient has perhaps been not the best endpoint that we've been using. And we've come to know that and be more sensitive to that more recently. So Davide, would you have gone with what he did?
I think they found a good compromise between not being too aggressive because it's a fragile aorta, but doing something because of the mechanical deformation.
Yeah. So you did.
I wouldn't do it.
And ran 22 true balloon or Atlas.
I'm in total agreement with their practice.
Yeah, now that I've seen the result, I also say yes. Would you have asked me before? I wouldn't have done it, to be honest, but the result is now better than before. So I would probably have not done it because he would
Sam, now I'm going to come to you then.
I totally agree with the double tap technique. I think that's really important because you gain a little bit more just from repeating it. But, there's no harm to this. It's 22. You're not going to fracture with a 22. I just don't think it gained much. But let's see.
If we are, guys, if we look at the post-deal again, most of the effect occurs on the outflow. You see the flaring of the outflow, which is always good. Yep. And the waste remains about 60% of the valve, the stent frame, just after below the post. So I think we did something, and it's a good compromise. And another point, Nico, you were mentioning that is the commissural alignment, which is.
Yeah, if you carefully look, but maybe we can just give you a shot of that, Didier. Yeah. If we carefully look at the post of the Octapro.
And now.
Yeah, so carefully look at the post of the Octapro related to the post of a mosaic. We have maybe a 5 degree of misalignment, but it's quite satisfactory. And you see, we are in the near cusp overlap view, meaning that on the right part of the screen we have the eyelets of the post of a surgical valve located between two in front of a commissure, and you see that we have. The commissure of a Myval that is more or less at 5 degrees.
Yeah, it's only 5 degrees. It's a minimal now. Yeah,
so I think it's quite satisfactory regarding that. And so as expected, looking at the hemodynamic recording, there is no residual significant regurg, which is fine. Yeah. And we discussed about the gradient. So. This is what we have, but I think considering the clinical history of that patient, his baseline status, what he was suffering from, and the origin of that was that AR, we may have done something that will help him.
We have two other questions.
What I propose, while Nico is going to answer the question, I'm going to just withdraw the Sentinel, the cerebral protection device, and then we're going to see if there is something inside.
Yes,
so I'll let you discuss,
listening
guys.
to the question,
Nico, in the meantime, we have two questions in the chat, and I'm trying to summarize those. One is related to the wire. Can you explain once more why you used a Lunderquist wire and not a simple Safari wire in that case?
Yeah, so I think it really have to be put in relationship with this particular issue of ascending aorta falls pseudoaneurysm. The idea, and it was also at the origin of our choice of balloon expandable valve with a steerable catheter, the idea behind that being to avoid at the maximum any risk of friction with the outer curvature and the lateral wall of the ascending aorta where this false aneurysm is coming from. So by using a Lunderquist, which is stiffer than the Safari, we felt that we would have a more central position of a stiff wire that would avoid those kind of friction and reduce the risk of interaction and then trauma of the ascending aorta.
And another question relates to the sheath. A colleague is stating here that in his experience or her experience, there's some bleeding issues with the sheath once you placed it. What are precautionary steps that you take to avoid that bleeding through or next to the sheath?
Didier, is it something that you notice?
Yeah, we can observe that from time to time. And the first thing is once you are inserting the sheath, you should counterclockwise, just to furthermore wrap around the sheath. And this is very important to make sure that the way it folds really is tightened a little bit more, and then you don't get that bleeding because it's not folded the appropriate way. The second thing is to you just pre-dilate it, I would say, with the dilator that is provided, just to get a kind of first expansion before you insert the valve or any catheter to get it a little bit more circular. So a couple of elements, and that can definitely prevent the bleeding during the procedure. Here there is a tiny residual bleeding, so we're going to just compress for a couple of minutes, and then it should be okay.
Yeah. Didier, would you consider, with such residual bleeding, would you consider giving a little bit of protamine, or is it something?
Yeah. The ACT was close to be 300 for this patient, so let's see. Let's see what we have on echo, and then we can all decide if there is a need to...
So Didier, can you just describe your closure protocol, which we notice here is a ProGlide and an AngioSeal. Do you close your 14 French inline sheaths with just? Do you manage to just close it with a single ProGlide? And in most of the cases, you may not need to put a AngioSeal in.
Yeah, in most of the cases with a single ProGlide and then an AngioSeal, you get an appropriate closure. And I will have to say, even for smaller valves, or you can close with only one ProStyle, and that's something that I learned traveling in Asia, and they do it with one ProGlide, whether it be Kentaro, Yoei, Yusuke. So the AngioSeal is an additional step just to increase the safety of the procedure. We have derived our practice from the double ProGlide technique. Because it's what we saw is that we have more bleeding and more stenosis at the end of the procedure. Here, we see that there is a superficial bleeding, but let's add a bit of color on it. There is a slight proximal flap. We see, if you watch on top, we can nicely see the track of the ProGlide and the AngioSeal. And if we scroll a little bit more proximal, despite that small flap that we could see, there is no impairment of the flow within the vessel. So here you can see a couple of dots coming through the location of the AngioSeal and the ProStyle, but nothing major. So I don't think that we need anything else. And I agree with you, Nico, maybe a couple of, we're going to antagonize the protamine for the heparin for the patient. Okay.
So isn't it your normal practice to reverse partially the anticoagulation with protamine?
I would say when we provide a big amount of heparin to the patient, I would say yes. particularly those with a cerebral protection device, those with a high body mass index, if you think that the closure is not going to be sufficient, because what we aim at is getting an early ambulation of the patients 4 hours after the procedure. So you have to make sure that the risk of bleeding is minimal. So if there is a slight oozing and so on, we give the protamine to make sure that we control this type of complications. But as you could see, so here we don't have any major bleeding, so I don't think that it's going to be an issue for this patient after that. So I guess, Nico, that was a very interesting procedure, challenging, so maybe you could wrap up.
Yeah, I think my main learning from that is how to adapt your strategy to the particle features of such patients, where we understood why the choice of a short frame balloon expandable valve for a valve-in-valve TAVI was an interesting choice, preserving us options for the future treatment of his false aneurysm. It was also, I think, a good demonstration of the excellent hemodynamic performance we can have with this platform, even in small annuli. And of course, the opportunity for us to go through all the conventional steps of deployment of such valve.
Thank you.
Thank you.
Great case.
You know, the problem with you guys is you do it so fast and you do it so neatly that you make us all, redundant, should we say. No, that is great, and that is great demonstration of the properties and the uniqueness of the OctaPro. I mean, the implantation and the precise implantation and the fact that the valve was so stable and deployed at the position and the depth it was intended to be was clearly demonstrable. And this, I think we've got time for a few more minutes for an interaction with the audience. Do we have questions coming in?
Yes.
Use the mic and put it here. We would like to interact with you all.
We have some questions related to the use of the pacemaker. Would any of you have used the existing implanted pacemaker for stimulation?
No.
No? It's too complex, right?
Absolutely. It means calling my pacer lab to come up.
Yeah.
I'm easy enough to pace it by myself.
So Didier,
Would you do it?
No, because you got to exactly as what Sam said. But Didier was correct to say that sometimes with the double curve Lunderquist, you have a bit of a harder time pacing over the wire, and you might have to scrape the coating off the wire before you put the clip on to get pacing.
So I think it's a very relevant question around this pacing issue, pacing on the wire versus in a balloon expandable valve pacing with a temporary wire in the RV. So Davide, any thoughts on that? Are you this fad?
No, let's say they
Is it a
made this
fad?
look so easy in the way they did that, of course, going into the setup of the pacemaker existing, it's quite cumbersome. So I think we would do the same.
Yeah, Ran, do you put a temporary wire in the RV or you use this wire for pacing?
No, I think that in this case, and actually most cases, we would use the wire, whether it's Safari or Landmark or whatever.
Yeah, and Dirk.
Yeah, completely the same. I think he had a pacemaker, so there was no need for a backup strategy later on, and in a valve-in-valve, obviously that's very rare anyhow. So I think it's a very good strategy.
So Dirk, you're one of those who's had experiences with OctaCar. Tell us anything else that
it was a beautiful
people
case,
have
wasn't
missed
it?
out or
No, it was a beautiful case.
add on
I
to
think
that.
the only question I would have had to the operators, but they're gone now, but we can now discuss that by ourselves, is what did they do with the flex system? I think they still had a little bit of flex in it when they implanted it. I think that was a pretty good decision, because otherwise they would have come too low on the left side, I guess. So I'm not sure whether they made that on purpose. I wanted to ask them, but now they're away. We need to do that on the floor tomorrow. But I think that's something that can be discussed. If the aorta would have been smaller, we tend to not use the flex system during the implantation. We completely reduce it to 0 again, because it is better for the implantation of the valve. So, but they probably did it on purpose, because you could see in the flow that there was a little bit of flex still in the system.
Ran, you had a comment?
Yeah, I mean, I would like to make the comment, because in the preparatory discussion we kind of debated whether the operator needs to use 23 or 21.5. And I think that the results would definitely indicate that they chose the right size, because even with 21.5, they had a bit of a waste, and they even had to dilate in order to get rid of some deformation. So I think that the sizing was correct, and it was based on the CT measurement, not necessarily on the label 27. So it was a good choice.
Yeah, Ran, but you got to keep in mind that they did use 2 cc's extra and then went up on the balloon, and they could have perhaps. I mean, I think we're still open to debate on that, around 21.5 versus 23, but they got a great result. They did what they felt was correct, and they showed us that that worked well. And I think that's very important. I think we want to stick to time, don't we? Therefore, we should go on to the talks. We had a great discussion, we had a great result, and I think we've learned a lot from this case. So let's go on to our next talk. So we have Christian here. Christian's going to take us through the COMPARE TAVI 1-year data. Thank you, Christian.
Thank you. I just opened it here. So thank you very much. I will go through 1-year outcome from the COMPARE TAVI trial, a head-to-head comparison of Myval versus Sapien transcatheter heart valves. These are my conflict of interest. So we established the COMPARE TAVI organization with the purpose to compare new transcatheter heart valves head-to-head against best-in-practice contemporary valves. We aimed to randomize all comers so the results could be applicable to daily routine. We wanted to provide short-term safety data, but also long-term durability data. The first study was COMPARE TAVI 1, where we randomized 1,031 patients 1-to-1 between Sapien 3 and Sapien 3 Ultra versus Myval or Myval Octapro. The inclusion criteria were any patients eligible for transfemoral TAVI with a balloon expandable heart valve, which is, in our opinion, 99% of all patients. The center experience should be more than 75 valves per year, and the operator experience should be more than 15 of each transcatheter heart valve. There were no actually exclusion criteria. So we aim for a primary composite endpoint of death, stroke, moderate or severe aortic regurgitation, or moderate or severe hemodynamic valve deterioration at 1 year, according to the VARC-3. We also had some Bonferroni-corrected secondary endpoints, which was TAVI-related complications, successful implantation of the planned valve, and new pacemaker within 1 year. And we had additional endpoints, secondary endpoints, which is hypothesis generating only. This was the power calculation with an event rate of 13%. And a non-inferiority margin of 5.3, we needed 1,002 patients. And to take the risk of dropout into account, we aimed for 1,062 patients. The participating centers were the 3 Western Denmark TAVI centers. We all have a huge experience with Sapien previously. We have a catchment area of 3 million inhabitants, and we do 750 TAVI per year at these 3 sites. So here you see the inclusion of patients over time. So we started in June 2020, and the black line is the total inclusion, and then you see for each of the participating sites the inclusion rate. Initially, we randomized between Myval, which was available in 2020. Then, due to patent-related disputes between the companies, we had to stop inclusion for more than 12 months. And when we resumed the study enrollment, Myval was replaced with Myval Octapro. We randomized 77% of all femoral TAVI procedures at the 3 sites. We included all kind of anatomy, bicuspid valve and tricuspid, also acute and subacute cases. The patient population was the usual. It was 81-year-old patients, 60% males, the majority New York Heart Association class 2 and 3. And as you can see, 80% had an STS score below 4. Here you see the primary endpoint. And as you can see, both in the intention to treat and then the protocol analysis, it proved that Myval was non-inferior to Sapien. And you can see here that the lower confidence interval do not cross the non-inferiority margin. So we could conclude that Myval is non-inferior to Sapien regarding the composite of death, stroke, regurgitation, and moderate or severe valve deterioration at 1 year. Here you see the secondary endpoints, and as you can see also in the complete case analysis, it showed the same. You can see for the individual secondary endpoints, the moderate to severe aortic regurgitation was in favor of Sapien, but in both valves it was a very low number of patients with moderate to severe regurgitation. Pacemaker was also in favor of Sapien, as was atrial fibrillation. On the other hand, moderate or severe patient prosthesis mismatch was in favor of Myval. Bleeding was in favor of Sapien, but it was mostly due to type 2 bleeding, probably from the sheet. Here you see the 1-year mortality. There's no difference. Also 1-year stroke, no difference. And the 1-year pacemaker, where we can see that it's higher in the octacore compared to the 2 other transcatheter heart valves. And then we decided to plot the effective orifice area measured by echo according to the annulus area measured by CT. And you can see for every size of the annulus area, you achieve a higher effective orifice area with Myval compared to Sapien. This is comparable to the findings from the Landmark study. So I guess we can say that COMPARE TAVI 1 is the largest one-to-one comparison of any 2 transcatheter heart valves to date. It's the first all-comer randomized trial, so we think the results can be generalized to daily clinical practice. And we conclude that the Myval transcatheter heart valves are non-inferior to the Sapien regarding the 1-year composite endpoint. And if you want to read more about the details, it was published last month in the Lancet. Thank you.
Thank you very much, Christian. And I think, Christian, can you remind us that you're presenting some subset analysis data tomorrow?
Yeah, tomorrow we have 2 late breakings. So one of them is the 3-year outcome from COMPARE TAVI, of course, the first part of the study where we randomized between Myval and Sapien. They have reached 3-year already in August. And the second late breaking is individual pooled analysis based on data from both COMPARE TAVI and Landmark, where we have collaboration between the steering committees, between the 2 studies and the sponsors of the 2 studies.
So be there to listen to that data. It's going to be news. Sam.
Hey, Christian, that was great. You know, the PPM, the patient prosthesis mismatch, makes a lot of sense, intermediate sizing. Is there a clue as to the difference? It was slight, but real, in the moderate PVL. Was it in the first generation, more seen in the first generation than the second generation?
No, it's both for Myval and the second generation, you achieve a higher effective orifice area. So it must be something with the design of the valve. Of course, you could argue that with the new Sapien Ultra Resilia, there are some evidence that it also achieves a higher effective orifice area. So maybe with that generation, it could be different. But there are truly differences for all sizes, whether you take the smallest or the largest, or whether you take Myval or octacore, you see the same.
I meant the moderate PVL.
Yeah, but it translates into, you can have a huge man with a small valve also, so it translates. Yeah.
Christian, the pacemaker rate being higher, particularly in the octa-core, compared to a sapien, why do you think that is? Is it a deeper implant? Is it because it's a longer valve?
So there can be three potential reasons. One is, of course, a deeper implantation. We are trying to looking into that during fusion imaging, fusion pre-CT with post-CT. We have post-CT scans on more than 500 patients, so we try to evaluate that. It could also be more oversizing. We were taught initially that we should oversize like 10%. In general, we oversize like 7%, a little more with the Myval compared to the sapien. I don't think that's the reason. And then the last potential cause could be that the skirt on the octa-core was rather bulky. That we learned when we switched from Myval to octa-core. Suddenly it was difficult to advance the valve through the sheet. I think it's different with the newer generation OctaPro, having tried that. Also, it seems more easy, so it has been modified again. So I think, but in general, yeah, I don't think you should oversize 10%. You should go for 5%. I don't think you should implant deep. You should go like 10-90. We tend to implant them very high with the sapien. We should do the same with the Myval octa-core. And then based on the CT scans, we probably will get some insights in the near future. Yes.
Thank you. Felix, is there other questions from the audience? Or?
Not to the presentation.
Okay. So we're going on to our last talk on the real-world experience with Myval Octapro. We're going to see some great cases from SECO.
Myval and sapien. Pros and cons. No, perfect.
Dear gentlemen and colleagues, it's a great pleasure for me to be here. So here we go. So basically, we, together with my friend Luca, we work in two different hospitals. We were the very first hospital in Italy when we decided to go with the Myval, with old generation. So we do have a kind of experience. Now we have the OctaPro that was launched in Italy in the end of October 2024. And it was exactly during the national meeting that we had. So the first case that I want to present was the first case that we did. It was during this meeting. So it's an old lady, basically nothing special. So with a severe stenosis, nothing special from the CT scan side, no that much calcification. The length of the coronary artery was fine. You can see just a spot of calcium in the right cuspid. The access was all right, was perfectly. And this is the implantation. So this one was the first case. And the first thing that I want to highlight in this case is that it's almost a ground zero, and it stays exactly where it was performed to do. So this is probably related to the fact that this valve have almost known foreshortening of the valve. So, and this was the first case. Then the second case, it's a very young lady, so 70 years old lady, that they had also another small, let me say, the first one was an OctaPro 23 and the second one is an OctaPro 23. So this is the CT scan, no mass calcification as you can see, so probably it's more like a degeneration like a fibrosis degeneration of the valve. So almost in this case, the CT scan. In this case, we had the alignment. So the access was great, was fine. And this was the implantation, was the procedure. Maybe in this case, it's kind of young, was a bit deep, let me say. But also in the deep case, the outer skirt of the valve really forgiven us of the deep implantation. No need of permanent pacemaker, and this is the final result. And this one, here we go. And the last case, it's a different case. So it's again an old lady, again a relatively small annulus, so 24.5. And as I can show you from the CT scan, now we have a lot of calcification. So we have some calcium, as you can see in the LVOT, and almost a lot of calcification in the cuspid. I will show you in a second. Here we go. So very much calcification. Also in this case, the alignment was clearly performed. The access was all right. And here is the implantation. As you can see also from the angio, you see there's a lot of calcification in the cuspid. And this is the implantation and the final result. And also in this case, the outer skirt really helped us to prevent any leak where you always find when you have a lot of calcification that it's just being in the cuspid. So basically my experience, like up to now, I have almost done 40 implantation of Myval Octapro, and I proctored like 15 to 20. So the permanent pacemaker rate was very low, lower than when the old system because of the foreshortening of the valve. So, and in this case, which is not much, I had just one patient that needed a permanent pacemaker that started with the right bundle branch. While in our center, the permanent pacemaker rate overall, it's kind of high. As you can see, it's 7 to 8%. So definitely Myval allows us to have a lower rate of permanent pacemaker. So by just the conclusion, when Myval Octapro is my must-go valve, so the first choice. So basically it's in the small annulus and is clearly showed by the effect of the orifice area that we showed for the whole day today. So in this case, we really should think if you are a balloon expandable believer valves, so you should really go with this type of valve. Then, of course, you have this intermediate size that Professor Serruis showed us before. That is not an issue because the eccentric of the valve, when you're overinflating or the sapien, you may have some eccentricity index of the valve. And of course, in challenging case, I personally performed a couple of valve in MAC or valve in valve or in ring in mitral position. Low coronary heights, because this valve is really predictable, and you are really able to predict the valve, and of course, in the young patient. Thank you very much.
Thank you very much, Seko. Thank you very much, Seko. Those were great cases. But I think it brought out elegantly one of the points which I also realized, that in the previous generation of balloon expandable, be it Myval or Sapien, we would have it deep enough to accommodate for foreshortening. And therefore, we would start off at 60-40 or 70-30 to end up at 90-10. In the first few cases, as I was implanted him, and I kept it at 70-10, 70-30 implanted at 70-30. And that was really distraughting that you had a deep implant, which you really didn't want to. And then so it got adjusted to the fact that you just put it at a depth where you want to implant and just implant it there. So if it's going to be 90-10, you're going to be putting it at 90-10 and implant it there. Do you realize that, in fact, Martin, that comment of yours, that deep implantation could have been one of the reasons, yes, those were inadvertent deep implantations,
yes, because
accommodating for the foreshortening
that you don't have anymore.
Yeah.
Definitely.
What is the rate of predilatation in your clinical practice? Do you predilate on a regular basis, or?
No, never.
So we're coming to the end of the session, and I wanted to tell you about a conflict of interest which I had, which I didn't put up on the slide. And I'm not apologetic for that. In fact, I'm proud of that. And that's this conflict of interest is that I'm an Indian. And therefore, I'm proud of the Myval and the Octapro series of valves. With that, I pass it on to Felix.
Yes, thank you very much. Very briefly, I'm going to summarize and conclude the session by the session's learnings. So we see clinical evidence is robust and building, and I want to invite you all to the Landmark one-year hotline presentation tomorrow morning at Theater Havan, 8:30, and you'll see more data on the one-year outcomes of this valve. We've seen a step-by-step implantation of the Myval Octapro in a valve-in-valve scenario with optimal hemodynamics at the end, a very safe and efficacious procedure. And the Myval Octapro with intermediate sizes and the OctaAlign technique and precise deployment. We've discussed that there is almost no foreshortening with that. The valve are important for lifetime management of these patients. With that, thank you very much to the panel for the great discussion. Thank you very much for the operators for a great live case. Thank you all for coming, and enjoy EuroPCR. Thank you.
Thank you very much. Thank you.
Oh, well.